So today we're going to be going over respiratory and hematology. So those kiddos with those disorders or those systems. So we'll get through respiratory first, and then I've got an activity. It's an embedded game in Nearpod. It's about, I think it's like 15 to 20 questions that we'll go over that are similar to questions that you may or may not see on the exam. And then we'll finish out with hematology. Okay? So we're going to talk about the difference between the anatomy and physiology of the upper respiratory system between kids and adults. We're going to look at the different respiratory disorders. We're going to look at the nursing care related to those and your interventions for those with respiratory illnesses. So what are some of the biggest differences in the anatomy in kids versus adults? Their size.
Well, like just the placement of like their trachea or their whole anatomy of
their whole anatomy. Okay.
And like the development, that they're not fully developed.
Yeah, right. They're not fully developed, right? So lungs in kids aren't fully developed until they're about 10-ish, right? 8 to 10-ish. So things that affect them, that would also affect us, affect them in different ways, right? They get impacted a little bit harder. What does that mean for our younger kiddos? So, say they get like an upper respiratory infection. How is their impact? How are they impacted differently than adults?
It's harder for them to get well.
It's harder for what?
Is it harder for them to like get well, to like get rid of the infection?
Okay, harder for them to get well, get rid of the infection. What did you say? Okay, they experience hypoxia a little bit more, right?
So well, they just like if they have inflammation or whatever, it's a lot more constricted than that.
Absolutely. So like when we get inflammation, yeah, we can feel it, but it doesn't really impact us a whole lot. We can still breathe. And then you add a little bit of mucus in there. We still have, we have a little bit harder time, but that same inflammation and that same mucus can shut off their airway, can completely block it, right? Because their airways are much smaller, it doesn't take much for them to block off their airway, right?
And I feel like they only give, I don't know, but it seemed like my daughter, she could only breathe out of one. Like, I mean, like her nose, she's like, maybe she don't know yet. I don't know. But like, it seemed like when she gets sick, like her nose is just like, she can't, like she don't know I don't know how to explain it.
Like she can't breathe out of her mouth?
Like both of them. It seemed like when her nose.
Or she's like, yeah.
Mm-hmm.
Yeah, so all of that mucus, right? And so like, as they're transitioning from like nose breather to mouth breather, or if they're just normally like a mouth breather or a nose breather, it impacts them a little bit more, right? How else does their developmental stages impact them when it comes to like an upper respiratory infection?
They're able to verbalize difficulty breathing.
Okay, so they're able to verbalize things, right, when they get a little bit older. Can our young kids clear their airway? No. What do they do with it?
Stays out in there.
They breathe it in.
You gotta get that little straw.
I love that thing. Love that thing. The nose Frida?
Yes.
Love it. Love it. My son hated it. I love it. When it's respiratory season and we do the BBG, the baby booger grabber that's attached to the suction, and we do a nasal wash on the kids, it's so satisfying to see all of that mucus come out and how much easier they can breathe right afterwards. Right? In addition to still staying on with clearing their airway, they can't cough it all out, right? So, our older kiddos into adulthood, we know that when we cough up mucus, we need to continue to try to get it out, right? But what do our younger kids do with it? They swallow it back down, right?
And they don't cough forcefully enough to even really get it.
Right, so it kind of comes a little bit up and then goes back down. So they can, one of two things, they can either aspirate it back to where it was, or they swallow it back down. And if they swallow it back down, then what happens? Does our GI system like all of that mucus in there? What generally happens? Yeah, they either throw it up or it does pass through, and then what's it look like on the other end? Very mucousy, right? It just passes through. So when we're talking about, and educating families about respiratory disorders and what to look for, one of the things that you want to mention is that with all of this mucus, and that, if their child is swallowing it down, that they're going to have some mucousy stools, right? If we don't educate on that, do parents freak out when all of a sudden their kid has like this massive blowout of mucousy stool? Absolutely, right? So that anticipatory guidance, right? What to look for and watch out for when our kids have those respiratory system illnesses in their system, right? Okay. All right, so we're gonna kind of break them into two different categories. We're gonna look at upper respiratory issues versus lower respiratory issues. So we're gonna start with upper respiratory. And where does our upper respiratory system start? Here, right, in our nose. So what things are most commonly affected there in the nose? Like the deviated septum, okay, right? All of that tissue in there gets inflamed, it's filled with mucus, and it then can pass to where? Ears. Yeah, it's exactly what I'm dealing with. Yay.
I do feel like because they're just smaller, all of that happens much quicker. Like the second
Oh,
their respiratory
absolutely.
is in their ears, it's gonna like,
Absolutely, yes. It's very common for kids if they get an ear infection, it can lead to a nasal infection or vice versa, right? It's just everything's so small that it happens so quick. Absolutely, right? Some of the biggest things that trigger upper respiratory things are your like allergic rhinitis or sinusitis, viral rhinitis. How do you tell the difference? What are those signs and symptoms there?
Fever, maybe?
Okay, fever. Most common with what? With viral? Sometimes. More so with bacterial than viral.
Like if it's more allergy, like I feel like my daughter knows and stuff just running stuff, but she not like, she can run around and stuff, but she's not like really sick.
Yeah.
So maybe it's like a cold, it's like, she's like down for the count, you know what I mean? Like,
Right, like it affects their energy level,
Yeah.
right? So they're not so active, like if they've got a viral thing or a bacterial thing going on. Okay. You talked about drainage. How does the drainage differ between those three?
clear.
Viral is clear,
Yeah, green.
bacterial is green, right? Green, yellow, gross, it's like cloudy, it's thick, right? What about allergic rhinitis? Is it also clear? Yeah, absolutely. Okay. So how do we prevent those three things? So let's start with the allergic rhinitis. How do we prevent it?
Well, they was like them flushes, I don't know, they told me to give her a lot of the nasal flushes and then that she could get some kind of like Claritin or something.
Okay.
Or, I mean, not, you know, like.
Yeah, like Claritin or Zyrtec.
For kids,
Okay.
you know. But that's all that I know.
That's what I was gonna
I
say,
keep them
the
away from.
antihistamines and avoiding the allergen.
Absolutely, avoiding their triggers, right? Whatever those allergens are. So if they've got allergies, they're commonly being followed by an allergist, right? Especially if they're heavily afflicted by those allergies, okay? So it's really good for them to know their triggers, stay away from their triggers. So like when the wind is blowing and dust is flying through the air, is that a good time for them to go out and play at the park?
No.
Probably not, right? So looking at the air quality and all of that, making sure that they're staying inside when it's not so great out so they're not affected by those. What about your viral rhinitis? How can we prevent that? What's your biggest way?
Stay away from people that's sick.
Stay away from people who are sick, and hand washing. Hand washing is huge. I will say this over and over and over. Kids are cesspools of infection, right? They love to share, and they share their viruses just as well as they share everything else, right? So hand washing. Hand washing is huge. And again, staying away from those who are ill, which is hard in the school setting, right? Because how many times do parents still send their kids who are oozing all over the place to school?
All the time.
All the time. Why? They might not have daycare. They might not have childcare, right? They can't stay home with their sick child because they have to go to work, right? There's a number of reasons why they might have to. Or they just don't care and they're going to send them anyway, right? But encouraging parents, if they can, you have to keep your kid home, right? So that you don't get everyone else sick.
Sometimes it gets hard when they're little too, because they are sick every other week.
They are, yeah. Yes, and yes, our younger kiddos do often get sicker more, right? Because they're affected more by those viruses, right? Their systems aren't able to handle those things, so they do get sicker, right?
Right here, my daughter, when she first started school, she never had a cold, and then she was sick for like a year, the whole year. So.
Yeah.
Then they build up their immune system and they're good.
Yeah, right? Yes. Just tell them to rub dirt on it, right? You want to chew on that? You want to chew on that nasty thing? Go for it. It's gonna build your immune system, right? Absolutely. What about sinusitis? So, like a sinus infection, right? So sinusitis is more of like a bacterial infection. So how would we prevent those?
I think that doing like the nose freedas and helping them get the stuff out as best we can.
Okay. That's after they have it though, but how can we prevent it? Kind of the same things that we already talked about, right? Your hand washing, right? Don't put your dirty fingers up your nose and expose your nasal passages to pathogens, right? Keep your fingers out of there. So a lot of it really comes down to just hand washing, good hygiene, right? Staying away from those who are sick, or with like the allergies, staying away from your allergens, okay? So when it comes to treatment, how are we gonna treat allergic? We kind of already talked about it, right? Those antihistamines, okay, right? Those antihistamines. What about viral rhinitis?
Just keep the patient, they have water, but just.
Keep them hydrated, right? Essentially, you're treating the symptoms, right? So if they're dehydrated, you're gonna give them fluid, right? If these upper respiratory things cause them to be admitted, because they will transition to a lower, right? So the same thing that's causing the upper will eventually cause the lower, and then they might get hospitalized, right? So then supportive care. If they need oxygen, we're gonna give them oxygen. If they need suction, we're gonna suction them, right? Either using at home, they can use the nose Frida. In the hospital, we will not use the nose Frida. We will use the suction, right? But again, we're just treating the symptoms, right? What about with sinusitis or sinus infection?
Because it's bacterial.
Antibiotics, right? Absolutely. So antibiotics, and again, treat the symptoms, right? If they're dehydrated, give them fluids, okay? When it comes to pharyngitis versus tonsillitis, or the combination of the both, how do you know if it's bacterial versus viral?
When they have fever.
If it's red without, I'm thinking of strep, like the white patches.
So strep is what most commonly causes this, right? So with bacterial, you're gonna have the white patches. With viral, it's just red. With bacterial, it is also going to be red, but you'll see those white patches all over the place, right? What are some of the other signs and symptoms you're going to see in a kid who might have pharyngitis or tonsillitis?
They don't wanna eat.
They don't want to eat. Okay. It's painful. They're going to complain that their throat is sore, right? It's hard for them to swallow, especially if their tonsils are huge, right? So you might see that it takes a little bit more effort for them to get something down, in addition to it hurting, right?
And the snore, when she had a really bad snore.
Yes, you might see that at night they snore a little bit more because their passageway is more occluded, okay? Most kids will complain that their throat just really hurts, right? As adults, when we get it, you hear that they say it's like swallowing like cut glass, right? Kids don't really know what that feels like, right? So they just tell you it hurts, right? When my son had it, I had no idea until the only thing that he said was that his throat felt like steel. And I'm like, buddy, what does that mean? Your throat feels like steel. And I was like, let me look in there. Holy cow, holy infection. Like, it was crazy. And we ended up, afterwards, he ended up getting his tonsils taken out. But I was like, man, how long has it been like this? And he's like, I don't know, a couple days. Dude is like, he doesn't feel pain sometimes, I think. Like, he broke his arm last week before, and he only took Tylenol twice. Yeah. I'm like, are you okay in there? Right? So, for these two, huh?
Is he safe?
I feel like he's safe. All right, so for pharyngitis tonsillitis, what's your nursing management? How are we going to manage these kids? Okay, so modifying their diet, so something that's a little bit easier to get down, right? Something that's soft, okay? Do we want something that's like really hot or really cold? Cool to like lukewarm, right? Okay. Popsicles are really good, right? That'll help with the inflammation, okay? But nothing really hot, because that will make that inflammation worse, right? How else are we gonna manage it?
Having those gargles with like warm water.
Okay, like a saltwater gargle, okay? If they're developmentally able to, right? Our younger kiddos, you really have to make sure that our younger kiddos really know how to do that before you try to do that, or we don't want them to aspirate, right?
I want to make sure she didn't lay down flat because I felt like she breathed better when she was up.
Okay, yeah, so maybe elevating the head of the bed, right, can help them breathe a little bit easier, right? If it's a bacterial cause, what else is part of our nursing management? Antibiotics, right? Because again, this is most commonly caused by strep, right? Strep throat, okay? Surgical intervention. We might have to, right? When and why might we have to intervene and do a surgical intervention? Recurrent infections. Absolutely.
Because they can't sleep well, it might affect them at school.
Okay, it could affect them in school. Absolutely.
My thought
Right?
is basically it was too big, there was no, like you couldn't get through it, so they had to do it because they said it would be blocked.
Absolutely, yeah. So these kiddos who have, like, if they just have one infection, not terrible, right? We're gonna be treated with antibiotics. They might also get steroids, right, to help with that inflammation as well. But if they have recurrent infections, like if they're getting one every couple of months, that's a problem, right? And we don't want to continue to have them go through that. So what is their surgical intervention? What are we going to do? We're going to remove the tonsils. What's also commonly removed with the tonsils? The adenoids, right? So a TNA is what we call it, a tonsillectomy, adenoidectomy, right? They're going to take both, okay? And for the most part, they will never get a strep infection again, right? Because the tonsils are part of what system? Your immune system. Yes, right? So they take care of that, and we get them out of there, and we never have an issue again. Where are you going with all that food?
My office.
Wait, so they can never get another one?
It's for the volleyball team.
Oh.
I don't want it to sit in the sun all day.
Oh.
Do not touch it.
Okay.
I know you.
All right. So we've worked from nasal down to the throat, and now we're going to talk about foreign body. Okay, so foreign body occurs most often in which age group?
Toddler.
Our infants to toddlers. So our infants who are like mobile and moving around and exploring their environment, and toddlers. Why are they most at risk? They put everything in their mouth, right? They are in their sensory motor stage, all right? According to Piaget. Have you guys all seen that? Okay, what does that stage mean?
They're exploring the world with their senses. They're learning.
Yeah, right, they're learning about their world through their senses and their motor function, right? So how they move around, what they're touching, what they're seeing, what they're tasting. So they want to put everything in their mouth because they think that's how they're going to learn about their world, right? So our interventions to prevent that are what? Safety, baby proofing, absolutely, right? Don't leave small objects around. Don't leave piles of coins around, right? Marbles are another one. So coins and marbles are like the biggest things. Batteries are another one, right? Okay. So for your nursing management, what does your assessment look like? What do you want to do first if you suspect that they have a foreign body? Do we want to check their airway? If you can see it, right? If they open their mouth and you can see it, really that's all you're gonna do, right? Our surgeons are gonna be the ones to go and grab that out. We are not. But if you can't see anything in there because it's down too far, we really don't want to go inspecting around in there because they could also have what? I mean, they could have a gag reflex that you might get thrown up on. Not where I was going. What other condition might they have?
Oh,
That
epiglottis, whatever.
epiglottitis, absolutely, right? What's epiglottitis?
Infection of the epiglottis.
The inflammation of the epiglottis, right? And so if we go in there and we start moving things around and they get agitated and they start crying, is that going to aggravate that a little bit more? Yes. And what does the epiglottis do? What does it control? Closing off the airway, right? And if there's too much inflammation in there of the epiglottis, what is it going to do? It's going to close the airway and it's not going to open, right? So one of the first things we want to do is get an x-ray. We want to know if something's in there, right? Or if it's an infectious process instead, okay? If we do see that there's something in there, or we've witnessed that they've ingested something that then gets stuck, we have two options, right? Our emergency interventions, we've got the Heimlich versus back blows. For what age can you start doing the Heimlich?
Once you can no longer kick the kid up.
Okay, okay. Toddler, right? And so about 12 months, right? They have to be standing in order to do the Heimlich, okay? If they are not able to stand, you cannot do the Heimlich, right? Because in order to do the Heimlich, they have to be standing, okay? Or at least in close to that position. So less than 12, we're gonna do back blows, right? So what does that look like? What position are they gonna be? You're not gonna hold them up here and back blow them, right? Yes, you're gonna sit, their head has to be lower, and you're gonna do those back blows, right? So the back blows in conjunction with chest thrusts. Yes, absolutely. I love that you're all miming what you're gonna do. Don't worry, I'll give you the terms, right? I'm gonna do this to my kids. Okay. Right? So when it comes to foreign body, the biggest piece of this is education, right? that prevention education. So you already mentioned some things. So making sure that their environment around them is free and clear of small objects, that you're giving them toys that are appropriate for their age, that don't have small pieces, that they could potentially like pull off and ingest, right? Okay, cool with that? All right, let's talk about croup. What is croup? What causes it? What? It's a respiratory infection caused by a virus. Rarely it can be caused by a bacterial thing. Most commonly, it's a virus. Okay? What are your signs and symptoms of this?
Whooping cough.
Seal barking cough.
Seal barking cough. Different from whooping cough. We'll get to that one. That is a whole other thing. So do not get that confused with croup. Your whooping cough goes with pertussis. That is a whole other infectious process that we'll talk about. Croup goes with that seal-like barking cough. Okay? They also sound very hoarse, like they've got a sore throat. Okay? What else might you hear? Stridor. Okay? Is stridor an upper airway or lower airway sound? It is an upper airway sound, absolutely. So you will not hear stridor in the lung fields, you're only going to hear it up here in the upper airway. Okay? What other signs and symptoms are you going to see in a kid with croup? Huh?
Secondary.
Okay. Maybe retractions? What did you say?
Secondary muscles.
Okay. That's if they're having respiratory distress. Not all of them have that. If it's bad enough, they could. What else might you see? Maybe fever. Restless. Okay. Are they gonna have it all the time?
Usually at night.
Usually at night. So these kids will be perfectly fine all day long, and then you go to put them to bed and they start to develop this cough, maybe some stridor. Okay?
Isn't it worse when they lay down?
It is worse when they lay down. It can be. Much like with any of the respiratory things, when they lay down, they have a little bit harder time.
Is that the association with the nocturnal symptoms?
They're definitely nocturnal symptoms.
Is
Yes.
it because they're like sleeping during that time, or
No,
is
I
it
don't.
something
I
that's
honestly don't know why. It's much worse during the day, or much worse at night than it is during the day. Like seriously, like they'll have a rough night, and then all day long they'll be fine, and then again at night they'll have that issue. Like I don't know what about it. It just makes it like at night. So we'll see all of those things that we talked about. They'll be fine. They'll not be fine. So if parents have a child who has this, what do we want to educate them about? What interventions are going to take place? What are we going to see? Okay. Okay. Do we want a cold humidified air or hot humidified air? Cool humidified air. Your textbook tells you you want them in a hot humidified environment. Well, we know that croup is a result of what? What? Viral. But what's it causing? Inflammation. And we know that if we add heat to inflammation, it does what? It gets worse. So why would you want to put someone with an upper respiratory inflammation into a hot, steamy shower? Do you think that's going to make it worse? Yes. Every pediatric nurse will tell you that is the most miserable intervention you can try. Don't do it. What we want them to do is cold humidified air, right? So a lot of what you'll see is that these upper respiratory infections occur during what time of year? Winter, right? So kind of later fall into kind of late spring-ish, right? Like September to April-ish in most of the country, right? When it starts to cool off. Here it's a little bit later because it's a little bit warmer here, so we don't see them as early in the season. But what also happens during that time of year? Where are the kids? They're in school, right? Those cesspools of infection are all over each other. So we see that increase of those respiratory, upper respiratory or lower respiratory infections during that same time frame when they're all together sharing their infections, right? With croup specifically, in most of the country where it cools off at night, right? I'm super excited that it's gonna cool off until like the 50s this week at night. So perfect timing for them to go outside. So because croup happens most often at night and it's cool outside, take them outside into the cool air. If it's not cool enough outside, one of the other things that you can do is put them near an open freezer door, and that cold air that they're inhaling will help with that inflammation. Most of the time that works. If it doesn't work, it is a medical emergency, right? That stridor that they're hearing means that their airway is closing off. That inflammation is getting to be too much. So we want them to come to the ER.
So for testing purposes, is steamy shower something we should?
No, it will not be a steaming shower. No, no.
So-
We want cold, humidified air.
Cold.
Cold,
You know,
humidified air.
back in the day, our mom and them, they talked about, take them in the bathroom and all that stuff.
Yeah, it doesn't work. It actually makes it worse. It
For
makes
all
it worse.
things?
For all of the respiratory ones, we want cold, humidified air. Yeah, because a lot of it is, there's a lot of inflammation going on, right? And if we add hot, steamy environment to them, it's gonna make it worse, right? So we want the cold, humidified air.
Well, I don't know if it was cool, but I'm saying whenever they get sick, they be saying it. You know, like.
I think the thought behind that is breaking up the mucus. to
Yes,
kind of-
so it is helpful for the mucus part. Specifically for croup though, there's not a lot of mucus, so that hot steamy shower is not gonna help. For the other ones where they don't have necessarily as much inflammation, that could help break up the mucus, but a cold humidified air will do the same thing. Yeah,
They got them cold and better.
cold is better. Yeah.
Harming the kids.
Yes, and we will actually, so in the hospital rooms, you know how they have like the green oxygen meter? There's also a yellow one that says air, right? And so we'll hook up a humidified bottle to the air in a bigger tube that opens to, like we'll tape it somewhere near where their face is gonna be. So we'll tape it to like the bed rail or the crib rail, so that cold humidified air just is kind of like washing over them and creating a more humid environment for them there. Okay. Our biggest interventions are that cold humidified air, right? We want them either outside, they can be placed near a freezer. Do not put them in the freezer and close the door. That is not gonna work. You're gonna wake up with a babesicle, okay? We don't want a babesicle, right? We want a kid who's still alive, okay? Not frozen solid trying to treat croup, okay? The side-by-side freezers work really well because you can just sit them on the floor with the open door and it just kind of washes over them, right? Otherwise, if they have like the drawer, they're gonna kind of just have to like hold them over it, which isn't ideal, and it's not like, they're gonna get tired trying to do that, right? But really, we only want them to do that for a couple minutes before like they come to the ER with that stridor, okay? And then when they get there, what are we gonna give them? They are gonna get a steroid, but we're actually gonna give something first because the steroid, while helpful, takes a little bit longer to kick in, right?
Oh, I know.
They're gonna get racemic epi, right? So they're gonna get a nebulized epinephrine, okay? What else do we give epinephrine for? An allergic reaction specifically, right? That anaphylactic reaction, okay? We know that that epi works on opening the upper airway, right? Croup is an upper airway disorder, so epi is what we need, right? Unlike with an anaphylactic reaction where we inject it, we're gonna give a nebulized epi. It's going right to the source, right? Okay, so you're gonna give it just like you would give like an albuterol nebulizer or whatever other nebulizer you have. That's how we're gonna give it. Okay. Once they have that, we'll also then give them the steroid, right? Because the steroid is going to keep the inflammation down, where right now we just need it down right now, right? And then the steroid will kick in. Okay, cool.
What about Vicks? Cause they be telling us to put Vicks on them too. Even socks. That's like
The Vicks?
Yeah.
Oh.
Vicks
Vicks has been around forever, right? Like that with like slap a slice of onion on your foot, like put the Vicks on and then onion in the sock, like it pulls everything out, right? All of these home remedies. It does help in that, like it does kind of relax everything and help open up the airways a little bit, yeah. You know, you have to be really careful though with the younger kids, because if they rub themselves and then touch their eye or anything like that, like that's, you know, you're gonna have a feral kid who's running around with their eye inflamed because they put Vicks in it, right? But there are other ones, like, what's the baby brand, like, no, like, is it like Barbies or something? Like, I feel like it starts with a B. I don't know, it's in the baby aisle, but like the company that like makes like that gripe water and stuff like that, they also have like upper respiratory, like it's kind of like a Vicks, but not like a Vicks. But essentially it's like a homeopathic version of Vicks. It works okay-ish. Less irritating to their skin. Cool. Kind of got through that kind of fast. Do you want to take a break or want to keep going?
I keep going, yeah.
Okay. All right. So those are kind of your upper respiratory things that we're going to take a look at. Now we're going to move into the lower respiratory system. Most commonly, the diagnosis that you're going to see for a respiratory admission is bronchiolitis. Okay. What does bronchiolitis mean? Inflammation of the bronchioles, absolutely, right? So the lowest
Bronchitis?
is not. So bronchitis is your larger your bronchi, right?
Oh, okay.
Where the bronchiolitis is much lower, right? So bronchitis is more of your upper lung field, bronchitis is lower lung field, right? Further down. Most commonly, the diagnosis behind it is, or the virus behind it is RSV, right? Or the respiratory syncytial virus, okay? Other ones that you're gonna see are metapneumovirus, parainfluenza virus, flu. When we have a kiddo who comes in and they've got upper respiratory congestion, lots of mucus, they've got a cough, what are we gonna do? How are we going to test for what they have? We're going to do a nasal swab, right? That nasal swab tests for like the top 15 to 20 most common viruses that we're going to see that cause this, this disorder, right? So the parainfluenza, there's parainfluenza 1 through 4, there's influenza A and B, you got like enterovirus, rhinovirus, the human metapneumo, RSV, but RSV is the most common cause, okay? Now, they all cause the same signs and symptoms. What are you gonna see? When you're getting your health history, what are the parents gonna tell you?
Or not know, others stepped up.
Okay, yeah, so it started with a runny nose or nasal congestion, right? Several days ago, and now has turned into what? Now what are you gonna see? Difficulty breathing. So they're gonna say that their child now has what? Maybe fever. Respiratory distress, right? What were some of those signs and symptoms again? Absolutely, right? That retraction, nasal flaring, head bobbing, right? All of those signs and symptoms of respiratory distress. That's most commonly why they come in, right? Because now their child is doing all of these weird things with their chest and trying to breathe, okay? Maybe they turn blue a little bit at home. They might have, you might see on their diagnosis thing that they had a BRUE. It's a BRUE, meaning a brief resolved unexplained event. So maybe they coughed up a little bit of mucus, they turned blue, and then it kind of resolved on its own, right? But we're gonna admit them, we're gonna watch them and observe them, okay? It starts early in the upper, and then our late stages, it moves down into the lungs, again, where we see the most issues and the most admissions. What is your peak incidence during this disease process? What days? What days? So about how long does this infectious process last overall? Longer. What'd you say, 8? About 7 to 10 days on average, right? Days 4 to 6 are generally the worst, okay? So if they're bringing their kid in on day 3, what is some of the education you're gonna go over with them? It could get worse before it gets better, right? And you're gonna tell them what it's gonna look like and what interventions you're gonna do, right? What interventions are we gonna do? Hydrate, droplet precautions, they're gonna be on isolation, right? Absolutely, right? Contact droplet. Okay.
So about the 7 days that'll be for the incubation, or that's how long it takes for that to be?
So their whole infectious process, so once they start showing signs and symptoms, before they're better is about 7 to 10 days.
Okay.
Yeah. Okay. So we're gonna hydrate them, we're gonna put them on isolation. What else are we gonna do for them? Are they gonna get antibiotics? It's vital, so they're not gonna get antibiotics. However, if we suspect that they've got like a pneumonia along with it that could be bacterial, they might. But most commonly, they're not going to be. Okay. Are they going to be on any sort of medication?
I think we make use Tylenol for the fever or something.
Tylenol for the fever.
But you just have to make sure they're drinking enough liquids.
Absolutely. Or that they're hydrated through their IV. Okay. What other meds might they be on? They might be on a bronchodilator. Maybe a steroid, right, if there's some inflammation, okay? Really, we're treating the symptoms, okay? So if they've got it, we're gonna treat it. If they've got mucus, we're gonna do what? Hydration, suction, right? Those are the two things. And humidified air, right? We can hook up their humidified air, okay? What other intervention could we incorporate to help with the mucus?
Nebulized medications.
We could? Like what?
Respiratory and bromide.
Okay.
With both. Percussion.
Absolutely. Percussion. Chest physiotherapy, right? Our younger kiddos can't break up the mucus because their respiratory system isn't strong enough, right? So respiratory will come in and they will do some chest physiotherapy every couple hours, right? So they're gonna take those little percussion cuffs and they're gonna pound on them to break up that mucus, right? Okay. You mentioned the ipratropium bromide. Not super common. We might use something else instead to help with the mucus. If they're old enough to take it, not for our little kiddos, they might be on a hypertonic saline solution, nebulizer, right? What is that hypertonic saline gonna do?
The small part's gonna break down mucus.
Yeah, it's gonna pull more fluid into that space to help break up that mucus so that we can get it out a little bit easier. Okay. Yep, it's a hypertonic saline nebulizer. Yep. Okay. All right. So when you're assessing them, right, what are you gonna hear? Okay, maybe wheezing, but wheezing really goes along with what? With asthma, right? So wheezing is most commonly associated with asthma. You might hear some wheezing if they have some sort of like mucus plug, right? Because really, what's the patho behind wheezing? Why are we actually hearing wheezing? Or almost closed off airway, right? We're trying to force a lot of air through a very tiny space, right? Like either through mucus or through inflammation, right? If you hear wheezing, or what other sounds? Did you say crackles? Crackles are what you're gonna hear most, right? Because there's mucus down there, right? And so the air going through that mucus is gonna cause like that crackling sound, right? So we want them to be up, changing their position, moving around. We're gonna have respiratory involved, right? They're gonna be doing their chest physiotherapy, okay? If you hear wheezing and you've done some sort of intervention and you no longer hear wheezing, but you also don't hear any breath sounds down below, is that an okay thing? No. What happened? You clog, well, not necessarily respiratory arrest, but they're gonna have some issues, right? Because you have now closed off that part of the airway, right? It has now been blocked completely, okay? Okay, whooping cough. What's whooping cough? This is pertussis. Can we prevent it? Yes. How are we going to prevent it? Which one? Which ones? Tdap and DTaP, right? At what age can they get the DTaP?
2, 4, and 6 months.
Okay. It's recommended for kids under what age, specifically? Under 7. Close. 6, 7. Alright, about 6, 7. For DTaP, it's for kids under 7. For TDAP, it is for kids older than 7. 11? 11. Okay. Okay. So, are they the same thing, essentially? Yes. However, DTaP is covering more for diphtheria when they're younger, where TDAP is covering more for tetanus when they're older.
So it is older than 7, and on the thing that you told us to focus on appearance of the letter.
So that's when they're gonna get it, right? So if they've had their DTaP, their TDAP they'll get at 11, right? But if they didn't have those, like if they were an unvaccinated kid and now we have to give them, and they're 7 or older, they will get TDAP.
Okay.
Yeah.
But you'll let us know if they got it or not. If they've been vaccinated or not.
Yeah, you're not gonna get tested on that.
Oh, okay.
Yes. Okay. Yes, so in an unvaccinated kid, if they come in, they're less than 7, they'll get the DTaP. If they're older than 7, they'll get TDAP. They're essentially the same things, it's just the DTaP is protecting more against diphtheria while they're younger, and TDAP is covering more against tetanus when they're older, right? Because now we're really worried more about them like getting poked by something rusty while they're out exploring the world and being kids, right?
Is it tetanus its own vaccine too, or no?
It is.
Okay.
Yeah, tetanus alone is its own thing. Yeah. Okay. Why is whooping cough such a problem? What are we going to see as far as signs and symptoms? Why do we want to prevent it so bad?
Oxygen really low.
their oxygen can get really low, right? It can cause encephalopathy, right, from all of their coughing, right? Because what does whooping cough sound like?
Bad, for a whole month.
Bad, even longer, right? The other name, one of the other names for whooping cough is the 100-day cough, right? It can last for months. The cough will linger without all of the other signs and symptoms. The other signs and symptoms will go away, but that cough will linger, okay? But it's so bad because they just cough, and while you're coughing, everything is coming out, right? They're not taking in oxygen or a breath of air, but they get to the point where they have coughed out so much there's nothing left to come out, so then they'll take in a whoop of air, so that's why we call it whooping cough, right? So it sounds very different than stridor, okay? Stridor is kind of like a high-pitched whistle, where it is definitely like a right, while they're trying to take in a breath, okay? Other things that we'll see, it could cause pneumonia, it can cause seizures, right? It's really detrimental for our younger kiddos, right? Because we talked about why their respiratory system is so different and how they are impacted much stronger or much more than an adult, right? They can't manage all of that mucus. They're still getting the same disease process, all of that mucus, but they can't manage it as well, right? They could end up with fractured ribs, ear infections, right? There are a lot of childhood deaths related to this, but we can protect against it, right? Actually, we can even start before birth, right? How can we start before birth? Get the pregnant individual the vaccine, right? We want them protected because most commonly, are they going to be the one around their baby the most? Yes, right? There are some situations in which they are not, right? Maybe they are giving their child up for adoption or they are a surrogate, right? So they're not going to be the one. But really the ones who are going to be around their child the most, we want protected, so they should be getting the vaccine, okay? So let's take a look at what that looks like. So, what did you notice?
Hold her up.
Sit her up.
Okay, she probably should have been up a little bit more. Okay, sit them up a little bit more, absolutely. What else did you notice?
She did not even take a breath.
It was really hard for her to take a breath, right? As soon as she was able to take one in, it just started coming right back out again in a cough, right? What else did you notice? What started going off in the background? Her monitor, right? Okay. Do we just ignore that monitor? No. We silence it. No, we do not silence it. We address it, right? What else did you notice? Okay, she's got an NG tube, right? Because are these kids gonna be fed orally? No.
Yeah, race for aspiration.
That's
Race
always
for
the saddest
aspiration.
thing when babies are sick. Like, they can't breathe and eat at the
They
same
can't,
time.
yeah. So we have to put down a tube, right? Or we have to put in an IV to keep them hydrated. What else did you notice? What doesn't she have? Oxygen, right? Should she have some oxygen on? Probably, right? Especially if her alarm is going off, right? She should have some oxygen on.
Do they
Right.
have to, trach these babies?
No, not always. If it gets bad enough, they might be in the PICU. We can somewhat manage these on the med surg floor, but if it gets to the point where their airway closes off or they're not able to breathe and their cough is so terrible, we could put them in a medically induced coma and ventilate them up in the PICU. Yeah. It's not actually common that these kiddos will have an IV because we don't want them to cry while we're putting it in because it could make their inflammation worse, right?
What is it that's common?
We don't often put an IV in them because we could make it worse. So, imagine that girl starting to cry, right? Like putting it in an IV, do you think that's gonna make it worse? Yeah.
I mean, is that why, so you have to cluster the care so they get rest?
Yes. Yeah, absolutely. So you'll do a lot of cluster care, for sure. Okay. There's not a whole lot of nursing management along with this. This is a bacterial infection, right? So they are gonna get what? An antibiotic, right? Are we going to suction them? Is there anything to suction? So this is a lower respiratory issue, right? So suctioning is really for their upper airway. We can do a deep suction, but we're not gonna do that with this because they could start coughing again, right? And by the time we were to go in and actually try to get the mucus, they swallowed it back down, right? So you could see that she did bring some up, and then it was almost like she was choking on it a little bit, but then was able to swallow it back down. Did you catch that piece in there? Okay. So for this, it's really just supporting their care, right? So a little bit of oxygen, we're gonna have to support them with their feeds because they're not able to feed orally, and a little bit of oxygen, right, if they need it. Versus in older adults,
Cover your mouth, Jesus.
She gonna be a pastor around culture.
No, I've been there.
okay. So, very different from our infants, right? There's still a look of panic on her face for not being able to breathe, not being able to catch her breath, right? But you could see that she was able to fully expel the mucus that came up, right? Our older kiddos are able to do that because we can talk that over with them and they are able to understand that, hey, when this comes up, you have to spit it out, don't swallow it back down. But for our infant in that first video, she wasn't able to do that, right? And so all of that just kind of goes back down. So they have the risk of aspirating it back to where it was, or swallowing it back down, and then their stools get that mucousy texture, right? Okay, go ahead and take a break, and then we'll come back and go over asthma.
Yeah, what do you want to pack by?
When do we come back?
It could all go down on one side.
Is whooping cough also contact droplets?
Yes. You'll find all of the respiratory disorders, for the most part, will be on contact droplet.
Wait, let me see here.
Do you want something?
Me too.
That will be bacterial or viral, right? There's the inflammation in the. So botulism is for honey or what?
Yeah, that's why they don't.
How do you use it?
No problem.
Oh, that's something?
So that is,
Okay, so I just, I highlighted this one, cut, paste, highlight this one,